So our lecture is the harms of prescribing, polypharmacy, deprescribing, and conducting research at medical school. And our speaker tonight is Harmanleen Singh, who is an incoming doctor graduating from BSMS in June 2024. He's a teaching mentor with the BSMS Outreach Team, a student and foundation doctor representative at the Royal College of Physicians, and a vice chair of the Overcome Research Ethics Board, pursuing his interests in research, medical education, and widening participation in medicine. So, with that, I will hand over to Harmanleen.
All right. Thank you so much, Zach, and thank you for having me. So, like Zach said, today's talk is all about some of the harms that might happen from prescribing, and we'll go into that a little bit more detail and then talk a little bit about research in medical school. So, a bit of background. Essentially, medicines have been a great contributor to the health of the entire population, especially over the last century or so. It's helped us treat illness, save and prolong lives for countless number of individuals. But one of the problems with this has been that as we become more and more reliant on taking medications to resolve our health issues, some problems have started to emerge with taking multiple medications at a time. And this is what we call polypharmacy. So polypharmacy is the use of multiple medications by patients. There isn't an exact definition for it, but generally it's considered to be 5 or more medications. The prevalence of this in the UK is estimated to be around 37%, and it's expected to rise with our aging population. As more and more people age, we accumulate more and more health problems, and more of these health problems are treated with medications. Now, polypharmacy in itself can be appropriate or problematic. And in this lecture in particular, we're going to focus on problematic polypharmacy. So this is a statistics. This is a graph I pulled from the Royal College of Physicians website, where they talk about Scottish adults and how many medications they take by age and the number of conditions. So on the left, you can see as the age of Scottish adults increases, the number of medications they take rises quite a lot. So over in green, you can see sort of 10, the dark green, you can see 10 plus medications as well. And the same on the right-hand side, you can see as the number of conditions you have increases, the number of medications you take will increase with it. So talking about problematic polypharmacy, the King's Fund report describes problematic polypharmacy as multiple medications being prescribed inappropriately, where essentially the intended benefit of the medication is not realized. Because ultimately we prescribe these medications for specific symptoms, for specific medical conditions that patients might have, but it's not always the case that patients end up with that benefit, and in fact, it can end up doing more harm than good. So this is what we're really talking about. This particularly affects older adults, like we talked about. As you get older, you end up having more medical conditions or comorbidities, and there's particularly a problem with frailty as well. In the sense, there's frailty more common in older adults, so they're more affected by a higher medication burden. And although we're going to be focusing particularly on older adults in this lecture, it's important to note that it also affects other groups as well, which includes children, especially ones with long-term medical conditions. They can end up on lots and lots of medications, and also those with mental health problems as well, because oftentimes it takes multiple medications to manage a particular mental health condition. And also, it's important to know in this context that it can also end up affecting more deprived individuals as well, because of the association with them being more likely to have more long-term medical conditions, which means they're more likely to have polypharmacy and problematic polypharmacy as well. Okay, so now talking about some of the problems with polypharmacy, it can lead to quite a few things. So one of them being reduced adherence. So this means if there's, if a patient's being burdened with taking lots and lots of pills, medications, and even things like injections and whatnot, they are less likely to be able to remember exactly when they need to take the medication. They might be more and more frustrated with the number of medications they have to take. There might be costs associated with these things. And all of this can lead to reduced adherence or compliance with the medication regime. So they might end up just not taking the medications as prescribed, which can lead to, that whatever condition is that you're trying to treat not being treated effectively. It can also lead to increased risk of adverse drug events. So there's a few reasons for this. One of them being the more medications you add into a person's body, there's more likelihood of drug-drug interactions. So each of these medications can start interacting with each other, and some of these, and that can build sort of nasty side effect profiles as well. It can lead to altered rates of metabolism because these medications are metabolized in different ways. So, if your kidney or liver is metabolizing multiple medications at a time, it may lead to some differences, and you might have reduced or altered drug clearance as well. And if, for example, your kidneys aren't as good as removing a drug from your body, and the drug starts building up in the body, you're more likely to experience the negative side effects as well, and potentially some toxicity with some medications. And the final bit is prescribing cascades. So this essentially talks about a phenomenon where you have an adverse drug event. So let's say someone's on, blood pressure medications for a really long time. This is an elderly individual or older individual who's been on this for a long time, and perhaps no one's reviewed their blood pressure in a really long time. And it might be, as you get older, your blood pressure just naturally drops somewhat. So it might be that they no longer need to be on this medication, but because they continue being on this medication, it can actually result in them having episodes of low blood pressure. And that could lead to something like a fall if they get up really quickly. They might feel really dizzy and they might end up with a fall. That fall can lead to all sorts of consequences. It can lead to them breaking any bones, having hip fractures, them hitting the head and having cognitive impairment. So this is what we mean by prescribing cascade. So it can lead to all of these unintended consequences, which then means that they have to have additional procedures. So they might have to have surgery for a hip fracture. They might need to be on additional medications like pain relief medications. They might need to be on bone protective medications, all of these things after they've had a fall, and all of that being caused by a inappropriate medication. So all of this sort of snowballs, and you end up with more and more medications. Another thing that can happen is with adverse drug events, sometimes it can be taken as a new symptom of a new condition. So it might be that you have a side effect from a medication, but when you go to a doctor, you don't necessarily know that's a side effect. So you tell the doctor about the symptom that you're having, and the doctor says, okay, if you're having the symptom, we have another medication we can put you on for it, on it to treat that symptom. So you can end up being on multiple medications just because you're treating the side effect of the first one. Another thing we talked about the increased risk of hospitalization. So in the sense of the adverse drug events we talked about. So one of the examples I said earlier was the fall. So that can lead to hospitalizations, but there's other adverse events that can lead to preventable hospitalizations. And we do know that polypharmacy in older adults is an independent risk factor for things like recurrent falls, which can be up to 2 times more likely to happen, and cognitive impairment as well. Okay, so looking at all of these problematic things that can happen with polypharmacy, what's one of the solutions to it? Well, one of the most simplest solutions to it is we need to stop them on any problematic medications. So this is the phenomenon, this is what we call deprescribing. So instead of prescribing someone more medications as a form of treatment, we instead withdraw problematic medications that the patient doesn't necessarily need to be on, and where the benefits don't necessarily outweigh the risks of being on that medication. So the official definition is the planned and supervised process of dose reduction or stopping a medication that may be causing harm. And the goal of this whole process is to reduce the medication burden we talked about earlier, and reducing the risks of adverse events associated with polypharmacy. And ultimately, the idea is you're doing this for the patient to improve the overall patient's health and health outcomes. So the benefits include reduced medication burden, and we talked about how medication burden can lead to less adherence to medications. It can also reduce the risk of falls. It can improve or preserve a person's older individual's cognitive function, and it's also a reduced risk of hospitalization and even death as well. So there's all of these benefits of deprescribing. So how do you go about doing something like this? Well, there's a stepwise approach that should exist ideally for deprescribing. So in phase 1, it's really, really important you start off with engaging with the patient. You need to talk to the patient, gather all the relevant information from them about, what medications they're taking, how often they're taking them, what they're taking it for. So what's the condition that each medication they're on for? It might be sometimes the patients don't even know, why they're taking medications. They're just taking it because, the doctor told me to. So, and then as a clinician or a doctor, it's your responsibility to have a look at those medications to see, is there a benefit from that medication? Is the patient benefiting? What are the patient's opinions regarding this medication? Do they feel it helps them? Do they feel it causes them side effects? And what's their adherence to that medication as well? So are they actually taking the medication as they should be? Or are they, just taking it once in a while? Phase 2 is identifying, from all the information you've gathered, you identify the potentially inappropriate medications from the list of medications, and then you make a decision. These are the medications that you consider, should I deprescribe them? Now, the things that you want to consider when you're thinking about what might be potentially inappropriate, you need to think about what's the indication. So what's the clinical benefit of this medication? Does this medication that they have even have a clinical benefit currently? So going back to the example of blood pressure we talked about, it might be that the patient's blood pressure is, if a patient's been on blood pressure medication for their whole life, and they're quite a bit older now, the blood pressure might actually be low or normal, even without the medication. So they might not need to be on blood pressure medication anymore. You can think about, what are some of the commonly overused medications and high-risk medications. So this could be some, potentially pain relief medications, or high-risk medications could be ones that are known to cause adverse effects or side effects, like falls or an impairment in cognitive function. So all of these things you want to consider. And especially you want to consider whether the patient thinks or suspects, or that this is causing them side effects or adverse events, because that can potentially be the main reason that you end up deprescribing the medication. The final step, and this is the most important one, is in phase 3, is shared decision making. So at this point, you've engaged with the patient, you've identified medications that you want to deprescribe, but it's really, really important that you talk to the patient about what they think, what they want to have, what they want to do, because it might, it's really good to have the patient on board with what you're doing. Because if you just deprescribe a medication without telling the patient about it or telling the patient the reasoning why you're doing this, they might have they might just not know why you're doing this. They might be like, oh, should I not be, is this not good for my health? It's really good to talk to the patient, engage with them, and come to the decision together. And this is where your planning and implementation comes in. So you need to think about how exactly you're going to remove this medication. Can you safely remove this medication altogether? Do you need to start tapering the dose? So do you need to start reducing the dose down in a stepwise approach over the course of, days, weeks, or months? And how do you continue monitoring the patient? So, for example, if you're removing a blood pressure medication from a patient, you want to make sure you follow up with the patient and have follow-up appointments where you take their blood pressure and make sure, when you've withdrawn the medication, they're still doing okay. So this is the process of deprescribing, but let's talk about some of the challenges. So we know that despite all of these benefits of deprescribing that we talked about earlier, the prevalence of these potentially inappropriate medication remains really high, and the actual percentages vary from study to study where you look at it, but it seems to be around 40%, and some studies even report it to be much higher as well. So it's quite clear that despite all of these benefits, deprescribing isn't quite happening when it should be. Not so what I want you guys to consider at this point is, what might be the reason behind this? Why, despite all of these benefits of deprescribing, despite us knowing about all of the potential harms of a polypharmacy and problematic polypharmacy, why does it seem to be that it's not that many doctors are deprescribing medications?
So somebody said there may be harms trying to remove medicine since that could interfere with how the other medicine works.
Yeah. And
Um, yeah, go for it.
so it's absolutely possible. And sometimes it might be that, we'll talk about a little bit more about this in a second as well. But yeah, absolutely. So there might be doctors or clinicians who are afraid of deprescribing a medication because of the consequences it might have.
Excellent. Yeah, this is a lot of people have said that reluctance of patients may be scared about possible consequences if they stop taking certain medication. A patient's fear of coming off a medication which has massively improved their quality of life. Yeah, lots of people talk about patients being hesitant about coming off of medicine.
Right. Do you know what? I'm really, really glad that all of you have answered, and a lot of you have mentioned this, because, I was actually wondering the same thing myself as well. And when I came across, this whole topic of deprescribing, I was quite fascinated about this, and I was wondering the same thing of, what could be the potential reason why it's not happening as much? And that was one of my thoughts as well. And in fact, I ended up doing some research into this. So I was quite curious about this. So I did this as part of a independent research project that I did. And I focused my research on a particular medication called a statin, which is a cholesterol lowering medication. And I looked at what are the perceptions of, so what are the attitudes of patients, carers, and healthcare professionals towards deprescribing statins? And a lot of these are similar to deprescribing in general as well. But my research focused particularly on this statin medication. So for this research, I ended up doing a systematic review, which is essentially where you scour the internet and all the journals out there for specific studies that exist out there. And you capture the ones that are relevant to the research question you have. You do this in a systematic way, which is why it's called a systematic review, which essentially means there's a protocoled way you go about doing it to reduce the risk of bias in the information you collect. And let's talk about some of the results. So, in fact, So some of the factors that we found that were related to that the attitudes people had, so this includes patients, carers, and healthcare professionals, were risk and uncertainty. So you can see I don't know if you can see my pointer actually, but one of the, let me just go back. Yeah, so one of the factors was risk and uncertainty. So that includes the patients, but in fact, from our research, what we found was that it was the doctors who were actually more concerned about the risk and uncertainty of deprescribing someone. And this particularly comes in when you have primary care physicians, so GPs, who might be hesitant, for example, to deprescribe someone who has been prescribed a medication by a specialist, let's say a cardiologist. And they don't want to take a patient off a medication that a specialist has prescribed, because it might be, oh, I'm going against a specialist. But in fact, it might be the right thing to do. They might recognize that, but they're just uncertain about, whether this would be the right decision. So they don't want to risk necessarily taking a patient off of it. Another factor that we found was perceptions. So perception about the medication itself. So in this case, it was the perception about statins. So this included mostly patient factors. So it included stuff that patients might have heard about statins in the media or news, or even from others. So that can play a key role in whether patients are open to deprescribing or not. Other things we found was essentially concerns about adverse effects. So that was one of the key facilitators actually to deprescribing. So if patients had adverse effects and they actually came in and talked to their doctors about them experiencing side effects or specific events that happened to them because of the medication, they were a lot more likely to be willing to be deprescribed. And so were the doctors as well. Other things included things like the perceived health and well-being of older adults. So one of them being, if a patient, for example, themselves thought, I'm quite fit and well, actually, why do I need to be on medications? So that could be one of the attitudes that the patients might have. But in fact, what we do know is if a patient is quite fit and healthy and they're less frail, they might actually need the medication a bit more because they have less of the risks less of the risks of adverse effects, and they're potentially more likely to have the benefits of the medication. So, for example, with statins, they're more likely to benefit of if they're already quite fit and well, they're more likely to benefit from not having future, cardiovascular risk factors like heart attacks and things like stroke. Whereas if someone is already quite frail and ill, their perceptions might be, I'm quite about their own health might be that they are not very healthy and they need to take medications. But it kind of flips on its head. So we know that if someone is already quite frail and quite old and not that healthy, the benefits that they have from a preventative medication like a statin, which is a cholesterol lowering medication, are a lot less compared to someone who is a lot more fit and well. So they are more likely to experience the side effects or the adverse effects of the medication and less likely to have the benefits of it. Other things that we found included things like organizational challenges. So this is, as you all know about the challenges in the NHS and the pressures that the NHS faces, but also all across the world as well. Because of all of these challenges, because doctors don't have enough time, because patients feel doctors don't have enough time. All of these things mean that patients are less likely to book in appointments where they talk about their own health and their medications, how they feel about that with their doctors. And if this conversation doesn't happen, that's the phase one of our deprescribing process, which is engaging with the patients. So if this process doesn't happen at all, the patients won't be deprescribed any medications. Okay, so these were some of the key takeaway points that we got from the research. So what we found was that the engagement of older adults and healthcare professionals varies based on a lot of different perceptual and practical factors. So it could be to do with what they think might be happening and the actual reality of the practical things around them. We found that actually older adults were generally quite willing to consider being deprescribed statins, and a lot more so than what doctors thought. So they've done a lot of research on this, where doctors generally state, like all of you did, they're quite worried about what the patients might think. Oh, the patient probably doesn't want to be deprescribed the medication because they think it's going to benefit them. But in fact, what the research that we saw found that when doctors approached the patients, talked about it, talked about the benefits of deprescribing with them and that they think it's the best decision for their health, when they were engaged properly about this, the patients were generally willing to be deprescribed. And a lot of the factors associated with this were having a high medication burden and feeling that there's a lot of adverse effects of the medication. And yeah, the healthcare professionals are generally a lot more reluctant to deprescribe statins. And the risk uncertainty was one of the most common barriers to it. Because ultimately, as a doctor or a healthcare professional, one of your main goal is to, do no harm. You don't want to be taking the patient off a potentially beneficial medication, and that ending up causing someone harm. It's also potentially to do with the psychology of these things of, people are a lot more willing to do nothing and have something, have an adverse event happen to a patient, for example, because there's a less of a connection with you having done something. Whereas if you did something, let's say you took a patient off a medication and the patient had, let's say you took them off a statin and the patient ended up having a stroke or a heart attack, you're more likely, the clinicians, are more likely to take the blame on themselves of them having done something wrong and that leading to a bad effect. So it's essentially to do with, avoiding that risk. And one of the main things that we found that would actually enable successful deprescribing was a collaborative approach to deprescribing and having a comprehensive framework where all of the relevant stakeholders are involved. So things like government policies, the societies, all of these physician societies that we have. So we have Royal Society of Physicians, for example. We have geriatric societies in the UK. All of them need to work together to come up with a framework and guidelines to help all of these clinicians overcome their uncertainty and risk and have an approach to deprescribe, essentially. And all of this will enable greater engagement with patients in having these conversations about deprescribing. Okay. Are there any questions at this stage at all?
And we had one question, Harman, which was what does the n equals 4 bit mean on your previous slide?
Okay. So that's just from the results table. So it's to do with how a systematic review works. It means how many studies we found that talked about this particular thing. So yeah, that it's just because that table I pulled directly from my results table from the research I did. Okay.
Perfect, thank
So
you.
moving on to the research bits then. So conducting research at medical school. So let me start by a lot of this is my opinion, so take it and my experience. So take this with a grain of salt, and but I'm happy to answer any questions that you may have about any of this. So I'll start by saying, research isn't for everyone. But as a doctor, it's really, really important that you can understand research and implement the best practices based on the most up-to-date research. So it's really important that you have a good grasp of things. You're able to understand what you're reading. You're able to critically evaluate what you're reading. So you need to be able to distinguish good research from bad research. Um, and see what the general consensus is essentially. And we do have things like guidelines for that, but it's really important that as a doctor, because you do have this medical training, you're able to understand where all of these guidelines come from. So talking a little bit more about my experience in research, well, I'll start by saying this, my initial interest in getting in, pursuing medicine as a degree and as a career came from, hearing in the news about all of these new and exciting research in medical technologies. And all of that is what actually, you know, resulted in me pursuing medicine as a career. And so I was really interested in it when I first came into medical school. But when I did come into medical school, you do get quite busy and bogged down with, all of your studies, the lectures, the placements, and exams as well, of course. So you don't, and also as someone who's completely new to this field, you don't necessarily know how you can actually get involved in research. So but luckily, at BSMS, we've had some excellent incorporation of research aspects into the course itself, which has enabled me to, find my way through the research world and, actually get some research done. So when I was in first and second year, we had something called student selected components. So this is where we were essentially able to pick a topic of our interest that's not necessarily in the main medical curriculum, and essentially study about it and do some research into that topic as well. And we ended up presenting at the end of that module about the findings that we had. So that was my first brief introduction into the world of medical research. In second year, we also had something a poster presentation where we took a particular medical article from a journal and made a poster for it and presented that in front of essentially our peers and doctors as well. And then it was in my fourth year when we actually had a independent research project. So this is when I actually did my systematic review where I've looked into deprescribing statins and the attitudes to deprescribing statins. And this was my first, full-on dive into being, leading a research project, doing a proper systematic review, which then went on to be, presented at a conference. And I'm currently working towards getting that published as well. So that was all really exciting. And it opened up so many more opportunities to me once I learned how I can do this research. And, I had the excellent guidance and mentorship from, senior lecturers and clinicians at BSMS as well. And yeah, other things that I've done on the right, you can see This is very recently. I recently did a report on dementia that I submitted to the Royal College of Psychiatrists, and I was awarded the Old Age Psychiatrist Prize by them. So this is a picture of me at the conference with them. And another thing that I did after my research project was I did some research into medical education. So this involved looking at peer-to-peer education, essentially, and its role in medicine and medical education itself. And what we found from that research was that, peer-to-peer teaching can be very effective. It can be cost effective, effective in the sense it's it not only was beneficial for the students or the learners in the peer-to-peer teaching, but it was also found to be helpful for the peer tutors who ended up learning and consolidating their own knowledge as well. So these were some of the research projects I did, and since then I've had a chance to present this at conferences and work towards publications, and yeah, so that's been my experience doing research at medical school. If you do have any questions regarding any of this, I'm happy to answer them now, or I've put in my email as well if you want to ask me any questions afterwards.
Perfect. Thank you very much, Harman. Yeah, we will move on to our Q&A part of tonight's session. So please do feel free to pop any questions that you might have for Harmanleen in the Q&A. That'd be great. So we have got quite a few that have come through just there, Harman. So the first one we have is it better to become a qualified doctor before going into research?
Okay, that's an interesting question. I mean, that's something I used to think as well, that when I first came into medical school, I thought, I'm not trained enough to do something like research and be taken seriously and these kind of things. But in fact, you can get involved in research at any stage. And we even have things like patient researchers, and that's a really new, exciting thing that's happening in the world of research. So the idea that you need to be a doctor or a clinician or to be already established to start research it's not true. It's something you can do if that's the route you want to take, but you can get involved and get started in research as early as you'd like. But it is obviously very important when you do something like this, you have the right supervision and mentorship to guide you through that process, because I wouldn't have been able to do any of the research I did just by myself.
Yes, on that note, we've got a couple of really good questions here about sort of doing research. So are there any research oriented like clubs or societies at BSMS?
Yeah, so I believe we have societies for all areas of medicine where you might be interested in, so all different specialities. And we do have speakers who come in who talk about all of this research as well. And yeah, but I'm not sure if there's specifically a society for it. But like I mentioned earlier, there is a significant research component to the course itself, where you do start learning about research from an early stage, essentially.
Excellent. Lots of really good questions here. So you mentioned how you had an interest in medical technology due to that you decided to go into the medical field. What interested you the most about medical technology?
Okay. Yeah, so I believe at the time I think this must have been when I was in year 8, I think. And I remember reading, first reading and learning about, things like stem cells and the potential of stem cells. And, I guess the promise is still out there of things we can do with stem cells, like growing and 3D printing whole organs and things like that. and that's still in the works. But that was one of the first things that fascinated me about, medical technologies and, new and exciting research, essentially.
Brilliant. Oh, we got a long one here, but it is good. I've read it through. So, in my experience, being prescribed a medicine means that a month after first having it, you have a brief talk about whether it's working or not, and then it is put on repeat for you. Would you ever consider making the process of having a medication put on repeat longer or more involved? For example, checking in over a few months before signing the medicine off, or trying to take the patient back off a month later, depending on the drug, to see if it's truly having an effect or if they've just gotten better.
Okay. Yeah, that's really interesting. So we do have monitoring that does happen, and it should happen at least for medications. And it depends on the type of medication because, and it also depends on particular practical circumstances as well, because I can imagine a lot of people are not necessarily attending their regular follow-up appointments. But, ideally, after you start the medication, like you mentioned, you might have a week or so of monitoring. But after that initial week or so, you should still have possibly, depending on the medication, it might be every 3 months, 6 months, or even once in a year. It should be reviewed, and you should speak to the patient about what their experience has been on that medication. And that being said, it's that level of monitoring is a lot more likely to happen if you are under specialist care, a lot less likely to happen if you're under primary care, which is one of the unfortunate practical situations. Yeah.
Excellent. Another question about your sort of topic here. So, what other reasons would you say why deprescribing isn't common?
Yeah. So, like I said, from the research we found, it's one of the main things is that doctors do have specific, well, doctors and patients both have specific attitudes, but doctors do have sometimes an attitude of, what would the patients think, rather than actually asking the patient and not having the chance to have that conversation with patients is one of the main barriers there. Because a lot of times if the doctors did have that conversation with the patient, they would actually learn about what the patient's experience has been, and it would actually sort of empower the patient to have that conversation. Because from the research, we also found out that patients sometimes feel, they have a perception that, doctors are really busy. So I don't want to really disturb them. I don't want to start complaining about X, Y, Z. I'll just, come in for one thing and that's it. So they don't necessarily go into the side effects they might be experiencing, and which might end up, triggering a discussion about deprescribing.
Excellent. We've had a lot of questions about your sort of route into medicine and your experiences with medicine. So I'll sort of bundle them in together so that because there are multiple ones. So I suppose it's what was your route into medicine? Why did you choose to go into medicine? What have been some of the sort of challenges or barriers that you've faced along the way? And what sort of specialty and path do you want to go down or you're thinking about in the future? That's to sort of bundle them all together because there's quite a few of those.
Yeah. Okay, so let's start from the beginning then. So my path into medicine. So yeah, obviously I knew relatively early on, I wanted to pursue medicine. And in fact, I actually had the benefit of having my brother as, a sort of mentor or someone who I looked up to, who also pursued a career in medicine as well. So I was sort of following in his footsteps, and I had someone to, guide me in that sense. But in other aspects, I did feel, as I knew as much as he knew, but I did feel like at certain points, I'm not really sure what to do. And it was, challenging in that sense. I actually didn't get into where I wanted to be in my first year of applying after sixth form. So I ended up, I actually wasn't sure what I would do, because I knew at that time I had applied to biomedical science as a backup option. But I knew, I really wanted to pursue medicine in my heart. So at the time, I just had to make the decision, and I decided, okay, I'm not going to do this. I took a year out, and luckily I happened to, through a series of fortunate circumstances, I happened into a role as as a teaching assistant in a primary school. So I ended up doing that for a year, and and I really enjoyed that whole process. It gave me plenty of opportunity to work on my application for next year, and I ended up here. So yeah, so that was my journey into medicine itself. In terms of going forward, so what was the next bit that they asked about?
So I suppose, why did you choose medicine? And some of the challenges that you faced as a medical student, and then what you want to go on to do afterwards. What sort of specialty are you thinking
Yeah.
about?
Okay. So in terms of why I chose medicine, I mean, I talked about a few things already. So I talked about my interest in, hearing about things like research. And, I was quite inclined in terms of the sciences. I was good at science and those kind of subjects. I was interested in it. And but at the same time, I knew I wanted to do something where I wanted to help people as well. And that was one of the things where I thought, medicine is the perfect choice of career for me. Um, so those were a few things that sort of motivated me. In terms of challenges I faced during medicine, I guess like with everyone, you do have lots and lots of studies, lots and lots of exams, and that's just standard. But also, um, whenever you have, medicine doesn't stop for anyone, and medical school doesn't stop for anyone, and there, if you have sort of personal circumstances which can happen to anyone at any stage, it can be challenging to go through that, especially if you're going through that by yourself. But luckily, there's plenty of support available, from the medical school, from friends and family to try to support you through that. So it's really important that, when you're in medicine, it's very easy to be sort of tunnel visioned and just focus on just academics, but it's really important to take care of yourself at the same time as well. And finally, I think the last bit was going into the future. So yeah, so I'm excited about, future career prospects. So there's quite a few. So one of my main things I'm interested is in internal medicine. So this encompasses, for those of you who are not in medicine might not know what that means. Essentially, it's the care of pretty much any organs inside you, and which doesn't involve doing surgery. So it's the typical non-surgical doctor that you may think of, which is based in a hospital, so not a GP. So that's internal medicine. And once you do internal medicine, you can then subspecialize into a particular organ, like, the heart, so cardiology, and lungs and so on. So that's one of my main interests.
Excellent. We've got a few questions here. So this one's it's a tricky one. So how do you tell patients they I'm not sure how it's worded. How do you tell patients they benefit from medication even though they feel fit and healthy without making them feel like their feelings are being ignored or invalidated?
Yeah, that's a really good question, and that is something that doctors do clearly struggle with. So one of the main things is, just having an open and honest line of communication with your patient. And sometimes that means you do have to spend some time with them. You have to allow them the space and time to express their feelings, acknowledge, how they're feeling it. And, in that context, go through the benefits and risks of, not taking a medication with them. Ultimately, if someone has the capacity to make a decision, you have to respect what their decision is. But you want to be able to have that conversation with them where you go through benefits and downsides, but give them the space initially to talk about how they feel. And also, if you do that, it gives you the opportunity to address any specific concerns they might have. So, for example, if they've heard something in the media about medications, vaccines, whatever it might be, if you give them the opportunity to talk openly about it without, you know, fearing like, oh, you would judge them or, um, yeah, if they're able to speak to you freely, it gives you an opportunity to talk to them and address any concerns they may have.
I think we've got time for maybe one or two more. So we've just had a really interesting one come in, and yeah. So how has the media negatively impacted deprescribing, or has it negatively impacted deprescribing?
I think it depends on the medication. It can go both ways actually with the media. So with the media, if there's a lot of news in the media about side effects of something, a lot more patients will start then looking out for certain side effects, and there's a sense of confirmation bias where they might not have noticed a specific symptom or a side effect, but because they're looking out for it, they've started noticing it a lot more happening to them, and they'll start complaining about that being one of the main reasons why they don't want to be on the medication. The opposite can also be true in terms of specific medications. I'm sure all of you in the news well, maybe not all of you, but some of you may have heard about this miracle weight loss drug in the media. And let's say you're a patient who's on that medication and you're experiencing side effects from it, or the doctor looking after you has noticed, oh, this is having a bad effect on your health, you shouldn't be on it. You might be like, but this is the miracle drug, why should I not be on it? So it can go both ways.
Excellent. Oh, I don't know if this is relevant, but we'll see. Have you conducted any research on gene therapy, considering its relevance as emerging medical technology? And would gene therapy be beneficial in addressing polypharmacy?
Oh, okay. Well, the first part I can answer as the answer being unfortunately no. That sounds, very exciting, but I haven't had the chance to do any proper research into that. But yeah, I mean, I would love to as well. But that being said, the second part of the question I can go into a bit more. So we do have a new phenomenon. Well, it's not quite new anymore, but there's a phenomenon in medicine of personalized care, and that's a new trend we're trying to move towards. So personalized care or personalized medicine, which essentially means that like we talked about, not all medications are good for everyone. So the idea being, if you might have certain genes, and we can identify certain genes where a medication works for someone if they have that gene, or it doesn't work for someone if they have that particular gene. And if you can identify that, then it's a lot easier to be like, oh, you have that gene, so you shouldn't be on this medication, or you have that gene. And that is kind of already happening in certain specific scenarios that I know of. So, for example, in more rare conditions where medications are a lot more expensive, there's a condition called spinal muscular atrophy, which has one of the most expensive medication that's been approved by the NHS. Um, so that's one of the treatments for it, and one of the thresholds for or one of the requirements for treatment is that someone must have a particular gene to be eligible for that treatment, because we know from the research that only people who have that gene are likely to have benefit from it.
Excellent. Well, I think that's all the time we have for tonight's lecture. So I'd just like to say a massive thank you to Harmanleen Singh for your lecture this evening. It's been really, really interesting. I know from the sheer amount of questions that we've had that it seems like everybody's really enjoyed and found it really interesting as well. Yeah, all that's left to say is thank you very much, everybody, for attending tonight's lecture. We hope to see you at another session soon. Thank you very much, folks.
Perfect. Thank you so